Welcome to Integrative Oncology Talk, where we discuss the latest science and opinions from leading voices in integrative oncology. Integrative oncology utilizes complementary therapies and lifestyle strategies to help those affected by cancer, using personalized approaches and evidence-based recommendations. This podcast is hosted by Dr. Santosh Rao, a medical oncologist and integrative oncologist, and Dr. Judith Lacey, a supportive care and integrative oncology physician, with support from the Society for Integrative Oncology, an international multidisciplinary organization whose mission is to advance the science and education of integrative oncology worldwide. The views expressed on this podcast do not necessarily reflect views of the participant's workplace or SIO and are not meant to offer medical advice. The information, opinions, and recommendations in the podcast are for general information only. Before making any changes in your healthcare or lifestyle, please discuss with your healthcare provider.
Welcome to Integrative Oncology Talk. I'm thrilled to be joined with my new co-host, Dr. Judith Lacey from Australia.
So hi, everybody. I'm really delighted today to be here, and I'm going to introduce our first speaker who will be joining us today, Dr. Sheila Garland, who is a registered clinical psychologist and associate professor in the Department of Psychology at MUN. She is cross-appointed to the discipline of oncology, and her research interests include sleep and cognitive impairment in breast and prostate cancer patients and how cancer affects young adults. She was also co-investigator on a recent study comparing acupuncture and cognitive behavioural therapy for insomnia in cancer patients. So it would be really interesting to see, to have her join us today.
And we're also joined with Dr. Ashwin Mehta, who's the medical director of the Integrative Medicine Program at Memorial Healthcare in Florida. He's trained in integrative medicine and also board certified in sleep medicine. His research interests focus on improving quality of life, and he's also created an Integrative Cancer Survivorship Program.
And today we'll be addressing sleep and cancer, and we'll try and cover quite a few topics, and we'll see how we go. Looking at the cause and types of sleep dysfunction in cancer patients, the effect of sleep dysfunction on the person, symptom clusters and the relationship of sleep in symptom clusters, how we assess sleep disturbances, and some discussion on how we manage sleep dysfunction, particularly using an integrative oncology as well as approach, as well as how these sleep professionals manage sleep dysfunction.
Looking forward to it. Well, welcome to another episode of Integrative Oncology Talk. This is going to be a really special episode for a number of reasons. One is that we have more people than we've ever had. We have Ashwin Mehta and Sheila Garland, and we have two guests, but we also have two hosts, and this is the first time that my colleague and friend Judith Lacey from Australia is going to be joining us. So welcome, Judith.
Hi.
Welcome.
Hi, everybody.
So
great to be here.
Why don't you get started, Judith?
I will, and I'm really excited to be joining you today. And I think we're talking about a topic which really interests me, as well as all of us here on this podcast today. And it's about sleep disturbances and sleep dysfunction. And for us personally in our integrative oncology unit, this is one of the most common reasons people see us when they report on their patient symptom scores. What are your main concerns? And it's sleep disturbance. So I thought we'd start with a question to Sheila about really how prevalent or common sleep dysfunction is in cancer patients, and when does it occur in the cancer trajectory, and if you can define it a little bit. So I'll hand over to you, Sheila, to start us on this conversation.
Sure. So yeah, when we talk about sleep, we can talk probably most commonly about something called insomnia, which would be people who report difficulty falling asleep, people who report difficulty staying asleep, non-restorative sleep. And this tends to happen at least 3 days per week, and then also happens for at least 3 months. So that's when it becomes chronic. Some of the best research that we've got followed patients from the time of their diagnosis and then all the way up to 18 months later. So they followed a sample of about 1,000 people. And what they found was that at diagnosis, about 59% of individuals were reporting insomnia symptoms. And then I think it was 32% were reporting insomnia. So these people were coming into the cancer diagnosis having extreme levels of sleep problems. And then while these prevalence rates did decrease over time, even 18 months later, they were still 3 times that of the general population. So it's definitely one of the most common sleep concerns that people have is insomnia. But we can't also overlook that, sleep is multifactorial. And one of the other sleep problems that can come, and it's often more prevalent in certain cancers, is sleep apnea or restless leg syndrome. So at least I would say that, from my experience, those are the top 3 sleep problems I see.
And is it more common at a particular time? I know that we see a lot of patients who say, well, I used to sleep fine, but now that I'm having my breast cancer chemotherapy, I really can't sleep, and this isn't getting better. Are there specific times in cancer treatment that we see sleep problems occurring, and does this continue? Is this something that gets better? And how do we map this?
Yeah, so I would also say that there's differences by cancer type. So women with breast cancer do report the highest prevalence of sleep problems. And we also know that there's certain treatments that are associated with higher levels of sleep disturbance. So one of them is chemotherapy. And that is in part because chemotherapy is often paired with administration of steroids. And so you've got some steroid-induced sleep disruption. Oftentimes, people aren't prepared for that. And so they start engaging in sort of maladaptive behaviors, or they get anxious about their ability or their problems with sleep. And then they start doing things and then anxiety builds. And so for a proportion of people who maybe are able to ride with that short-term disruption in sleep, it may not turn into a chronic problem. But people who find it more difficult to cope, there are about half of individuals that are going to continue on and their sleep problems are going to persist. And for the remaining individuals, it does resolve with time.
So you're saying that for some people, they don't have a sleep disorder coming into chemo, but because of the adjustments they have to go through getting chemo and being on and off steroids, they develop a sleep disorder that persists? And
absolutely.
I know that another big cause of sleep disturbance is hot flashes for breast cancer patients. Pain is another big one. So let's talk about that. I mean, Ashwin, how do you assess somebody who has a sleep disorder? And I think one of my questions also is we talk about sleep, but there's a whole bunch of different things, obviously, that contribute to it. But I think one of the things that is often focused on in research is the amount of sleep somebody gets. Can you talk a little bit also about the difference between the amount of sleep versus quality of sleep, and whether we know, the difference in effect of those kind of things?
Sure. Well, certainly, I think the best way to assess is to ask. Everybody has their individual sleep story. I sometimes describe sleep as a 4-movement symphony. So if every organ system in the body is a different instrument section in a symphony orchestra, they all have to play in a coordinated manner to transition from one stage of that symphony into the next, which is like transitioning from one stage of sleep into the next. And oftentimes there oftentimes are ways that we can get at which is the predominant problem. Is it a short sleep duration that is an issue, or is it diminished quality that is an issue, or is it a combination of both, which it certainly can be. Oftentimes when people ask me how much sleep should I be getting, what they're really asking me is how little sleep can I get away with? And they're asking for kind of a set number, so that they can kind of justify really not making a whole lot of lifestyle changes or modifications to their sleep habits, and really persist in certain behaviors that aren't conducive to good quality restorative sleep. So I'm a big advocate for focusing on sleep hygiene, and also coming up with a nice bedtime routine. And that can be also very individualized. And this is where kind of motivational interviewing come into play. Use of bright screen electronic devices is so rampant. These bright screen electronic devices are kind of scientifically formulated to stimulate the arousal center of the brain. Not only the number of lumens or light energy that they emit, but also the content is designed to be stimulating. So, it's important to keep those things in mind, that, the recent research shows that artificial light at night can also contribute to weight gain in women, and I think in men as well, although the study was actually focused on women. So these are the kinds of things to keep in mind when coming up with a good bedtime routine. And I think one of the two main questions that I ask my clients who are coming in for a sleep evaluation is, number one, on most mornings, do you wake up feeling refreshed? And number two, do you feel like you have enough energy to get done what you need to get done during the day? And that's kind of what starts us off on the conversation.
That's really interesting, Ashwin, because it's really teasing out what is it for that person and how do you help them, set up to be able to get some sleep. You mentioned something really interesting, which was the impact of light. And I know there's a lot of work on the relationship between the circadian rhythm and circadian rhythm disruptors. And we often talk about, prescribing melatonin to help people get off to sleep as a way of maybe perhaps influencing the circadian rhythm in some way. And I'd be really interested in both of you and your points of view as to how the circadian rhythm and disruption of the circadian rhythm influences sleep disturbances and how that can influence the way we manage it.
I can talk first. Sure. So I think I get asked about melatonin all the time, and really, one of the challenges is that oftentimes, once the sleep problem has been around for a while, there is a certain level of anxiety around it. And no matter how much melatonin you take, it's not going to get rid of that sleep-related anxiety. So melatonin is not potent enough to be a hypnotic or a sedative, in that way. So, you can have, perfectly fine melatonin and still not be able to sleep. So there has been research conducted, not in the area of cancer, on the effect of melatonin in individuals with insomnia. And really it demonstrates that it is no better than placebo. And that's specifically for the treatment of insomnia. Melatonin administration as a method of reinforcing proper circadian rhythms, or in the treatment of breast cancer, that's a little bit different. But at least when we're talking about people who have difficulty falling asleep, difficulty staying asleep, melatonin isn't that helpful. It is indicated in the treatment of shift work disorder, jet lag, and people who have circadian rhythm sleep disorders. So somebody who might be a night owl, and the tendency to have that eveningness chronotype has been associated with poor mental well-being and some other physical health problems. So those people can use melatonin to kind of shift themselves a little bit back. But melatonin for the treatment of problems falling asleep or staying asleep doesn't have a good evidence base.
I agree. I think of melatonin as kind of a dose of darkness, and I also gravitate more towards behavioral anchors of our circadian rhythm. So, Judith, you mentioned disruptors, and certainly, for example, exposure to artificial bright screen electronic devices at night can be one of those disruptors of a circadian rhythm if used habitually. But I also like to focus on the anchors. What types of circadian anchors can we establish in our routines? One of those anchors is actually exposure to morning light, natural morning light. And if you couple that with exercise, I think it's a really nice behavioral anchor for our circadian rhythm. And the other thing is to have a nice kind of quieting down routine in the evening time, which is void of bright screen electronic devices, and ideally, in a quiet and dark space. This can be mindfulness practice. It can be aromatherapy. It can be mindfulness with aromatherapy. It can be, a relaxing cup of non-caffeinated tea. These are the kinds of things that can really help us anchor our circadian rhythm, both in the morning time when we're waking up and in the evening time when we're getting to sleep.
I think it's also important to mention, you mentioned night shift work, the importance of sleep disturbances, that night shift work has been associated with an increased risk of breast cancer. There are clock genes that basically, can either turn on and off based on whether you sleep enough. And obviously, we all know that there's immune changes with sleep disturbances, obesity you mentioned, with hormonal changes. There's a lot of things that go into that. You mentioned nighttime routine. I'm just going to throw this out there because it's something I don't talk about that much, but I've heard is there a relationship between sexual activity and sleep? Because we don't talk about it, but for many patients who go through this cancer journey, that's actually totally disrupted. How much does that affect sleep routine?
Well, I would say that, ultimately, good sleep hygiene means that you're using the bedroom for sleep and intimacy alone. If you're referring to, the sort of endorphins and their impact on sleep quality, it used to be kind of a widely held notion that exercise, for example, too close to bedtime might actually disrupt sleep quality, where actually that has found to be kind of debunked, and not actually the case. So, certainly intimacy can be part of a very healthy bedtime routine. And it's important for us to ask about it. I think that part of the issue is that we oftentimes see people who are struggling with daytime fatigue, who are feeling depressed, who have a lot of anxiety and worry, which are precipitators for insomnia. And we see this sort of constellation of symptoms, and we kind of gloss over the sleep part. So I think one of the most important things to do is to really acknowledge that sleep is oftentimes a mediator for many of these, for whether it's cancer-related cognitive impairment, daytime fatigue, mood changes, heightened degrees of inflammation that are contributing to pain, and sexual dysfunction. All of these things can have correlates with sleep. And so I think the first thing to do is just ask about it, and ask about sexual function and intimacy with one's partner. And I think that's a really good starting point. When you'll be amazed at how much you discover when you start to ask about what is your bedtime routine, what is your morning routine. It's up there with, are you exercising and what are you eating and drinking on a regular basis? So, certainly sleep is a central pillar of an integrative oncology practice. And I think one of the best things we can do is just get into the habit of asking about it.
It's really interesting, isn't it? When we talk about integrative oncology, we ask a lot in our interviews. We tease things out. We want to know, are you having hot flushes? Are you sleeping well? What are you eating? What is the quality of your sleep, what your cognitive function is like. And we try and develop this approach that will address those symptom clusters. But the cause and effect, teasing that cause and effect out, I find really fascinating. And I think it influences how we develop an intervention for somebody. You mentioned that a little bit with the cancer-related cognitive impairment and sleep disturbances. So if somebody doesn't sleep well and they're having hot flushes, will their cognitive impairment get worse? If we fix their sleep, are we improving their cognitive impairment? Maybe, but maybe not. And if we fix their if we do exercises to improve their cognitive function, does their sleep improve? How in practice would you tease that out to try and develop a meaningful intervention for your patients?
That's a really good question, Judith. I think some of the research right now that has been prospective actually identifies fatigue as one of the first symptoms to appear. And because fatigue is also has components of physical fatigue, but also mental fatigue, emotional fatigue, it has it's more than just feeling tired, right? But based on those feelings, then people can start to get more depressed, and they can start to feel mentally foggy. They can start to take naps during the day. They can start to feel, less, they might be feeling tired because they're fatigued, but they may not be feeling sleepy. So they start engaging in other things to try and make themselves sleepy. So, the relationship between fatigue and sleep is very interesting. But it does seem right now that fatigue seems to be first. And then sleep problems can follow. But then once they're there, they reinforce the fatigue. I see sleep problems as a bit of like a gateway symptom, because once you can dig in there on the sleep, you can improve that. And we know from the literature that you improve sleep, a whole host of other things get better, and you don't even have to touch them. So we know that fatigue gets better when you improve sleep. We know that cognitive function does. We know that depression and quality of life and pain and everything else. It's also really good once you improve sleep to see, okay, what's remaining? And then you can maybe do some more targeted intervention on the things that are still there after okay, well, we have you sleeping enough quantity. We have you sleeping at the right time. You're satisfied with the sleep that you're getting. Now, how else can we improve your life?
Agreed. And one of the studies that I enjoy referencing most is the YOCAS study, the work of Dr. Karen Mustian. And she, in her research, she found that indeed, the practice of yoga can improve cancer-related cognitive impairment and improve cognition. And actually, the mediator was found to be better sleep quality. So sleep is oftentimes when we befriend sleep, we're better able to decatastrophize the nighttime awakenings that we may have. We may quell some of the anxiety about sleep itself. So that's the wonderful paradox about sleep, is that oftentimes sleep disturbances, as Sheila mentioned earlier, they have precipitating factors and then perpetuating factors. And anxiety about sleep itself can be a perpetuating factor for things like insomnia, for example.
And I'm really intrigued by some of the studies looking at cancer-related cognitive impairment and functional MRI, and then sleep disturbances and functional MRI. And it's not necessarily the same part of the brain that is lighting up, if that's a way of simplifying the results. Do you want to just comment a little bit about that, how we tease that out and understand what's going on? So, is it in sleep disturbances, there's work looking at the hippocampal centres and the changes there, and in cognitive impairment, it is other centres of the brain that are potentially impaired. And so we're saying, well, if you get better sleep, does it improve your cognitive function? And is there a relationship? So I'm intrigued, but I don't know I don't know the answers, so I'm just throwing it out there.
I think we're also collectively still unraveling so much of the science in sleep. One of the studies that I was fascinated by most recently was, what happens in slow wave sleep during stage 3 sleep. These slow rolling delta waves actually coincide with almost a rinsing that happens. So they've found that, especially in patients with Alzheimer's dementia, as kind of a really pronounced cognitive impairment that we see, unfortunately, all too often. That rinsing of the brain that occurs during during stage 3 sleep actually is kind of washing away some of those proteins that can form beta amyloid plaques and such that are precursors and even harbingers of worsening cognition. So what's fascinating to me is yes, there's so many different areas of the brain involved to both maintain wakefulness as well as contribute to healthy sleep architecture, but it's also the timing of these mechanisms that we're understanding better with regard to improving cognition.
And Sheila, I was curious about what you were talking about earlier with symptom clusters. That's something that we're learning more about, that many of these things, whether it's fatigue and depression, for example, or pain and insomnia or sleep disturbances, how do you tease that out? You see somebody who has pain and tells you in clinic, I'm in pain and that's why I'm not sleeping, and you focus on the pain. How often is it where it is a symptom cluster? And can you tell us a little bit more about maybe what's the mechanism of some of those symptom clusters and how you kind of viewed that patient in that light?
So I guess I would say that it's very rare that you get somebody coming in and just presenting with one thing. So you're almost normally dealing with symptom clusters. So the way you might approach that might be based on the patient's preference, what's causing them the most distress at the time. You might also go with, what might be easiest to change and what might have the biggest influence on other things. You might even ask the question like, if I took your pain away, do you think that would take all of these other symptoms away? And if the person says yes, right, then, okay, let's focus on that. But if the person says no, then, that may not be your target. It's almost like you're looking for somewhat of a linchpin, or, if I knock this down, what kind of collateral impact might it have on other ones? And I feel like that's a very efficient way to proceed with personalized treatment.
But some of these things can be interrelated, basically, like your sleep dysfunction can cause fatigue, for example, and depression. And similarly, pain, we know the causative, but is there, in terms of mechanism, is there an overlap?
Oh, certainly. And I think Ashwin talked about this as well. Like, we know that there's inflammatory processes that are happening that are being influenced by or that are influencing the presentation of all of these symptoms. And so I think that that's why you do have to look at it in more of a system, because they are interrelated. So if you have one that you can target, then you're likely to have benefits on the others.
Agreed, Sheila. So for example, according to the National Sleep Foundation, 66% or 2/3 of people who are experiencing chronic pain also have sleep disturbances. There have been some pilot studies, quite small sample sizes, that have been looking at substance P as one of the mediators. So in one study that was actually looking at people with chronic pain syndromes, like fibromyalgia, for example, looking at how massage helps improve both the pain and this cluster of poor sleep quality and sleep being disturbed by pain. And they found that substance P was a decrease in substance P was one of the associations that may have contributed to both less pain and less sleep disruption, just as an example. And I think this is it's a really important topic. This topic of clusters. I oftentimes, when any symptom that I'm sort of told about, I ask my client, well, are your hot flashes impacting your sleep quality? Is your pain waking you up from sleep? Another really important or common one that I see is depression and mood changes and sleep loss. So it's really important, I think, for a clinician to kind of drill down. What is sort of the biggest contributor here? Is it that somebody is depressed and therefore can't sleep, or is somebody really not sleeping well and frustrated which is kind of creating that learned helplessness to contribute to the mood changes and the depression. And the reason that's important is because, so often, medications that we commonly use to treat depression, SSRIs most notoriously, are actually REM suppressing medications. So, it's really important to kind of drill down to which is the biggest contributor. And I really like Sheila's idea of really asking the patient to reflect, if we were to take your pain away, or if we were to take your depression away, your hot flashes away, do you feel like you could get good sleep quality? Instead of sort of having sleep be this sort of universal casualty of every symptom that comes up.
I think the beauty of integrative oncology and the work that we're doing is that we address symptom clusters. And I think my background, part of my background was studying Chinese medicine diagnosis. And I think using and working in a multidisciplinary team with acupuncturists, when you see these symptom clusters, they're addressed so beautifully by acupuncture, by massage, by yoga and qigong and exercise. And we're actually we're diagnosing differently. We're seeing that relationship between sleep disturbances, hot flushes, diet, exercise, love of hot or cold foods, bowel habits, and trying to put that into a diagnosis that's outside of the Western framework, and then treating according to that diagnosis. So I think that sleep disturbances is something, and I'm very interested in the work with Jun Mao and others in sleep disturbances and acupuncture, and comparing that to CBT. And are we actually contributing far more than other practices in as far as sleep is concerned? Are we looking at it completely differently? And when we're talking about management, actually looking at clusters. So I thought, since you're on this paper, Sheila, you wouldn't mind maybe commenting on how you went about, why you chose to look at these the factors that shape preference for acupuncture or cognitive behaviour therapy, and why you thought acupuncture was so important here.
Oh, certainly. So there's one paper before this one, actually, which was our primary outcomes paper. It came out in it was 2017, and it was published in the Journal of the National Cancer Institute. And we compared acupuncture to cognitive behavior therapy in 160 cancer patients, specifically with insomnia. So it was the largest trial largest insomnia trial in cancer, and also the first to compare two active interventions. And the reason that we wanted to look at acupuncture is because there's a great deal of research that has supported the model of hyperarousal in insomnia. And Ashwin talked about it as, you can have this hyperarousal level, which might predispose you to have insomnia, but it can also kind of perpetuate it. So kind of make it stick around or maintain it. And so there is the suggestion that that's one of the methods, or one of the mechanisms on which acupuncture might work, because it might kind of balance out or kind of target these arousal pathways. And cognitive behavior therapy comes at it from a different way. It targets the behaviors that are maintaining this arousal and the thoughts that are maintaining this arousal. So fortunately, I had quite a bit of experience in cognitive behavior therapy, and Jun Mao had quite a bit of experience in acupuncture. So it was a nice blending of our worlds. And overall, what we found was that cognitive behavior therapy for insomnia, it did come out as the treatment with greater overall effect. However, our primary outcome was the Insomnia Severity Index, and that has been established to have a minimally clinically important difference value of about 8. And the acupuncture group exceeded that minimally clinically important difference value. It didn't quite get to the CBTI level, but it made a minimally clinically important difference. And I was quite impressed to see that. I wasn't sure. We didn't know. I had nothing really to expect, and I was like, I was really impressed by that. And we also found that it was different by group. So people with pain actually had a stronger response to acupuncture than the people without pain. And then we did some follow-up qualitative interviews, and what we found is that the people who preferred acupuncture a lot of people were curious. They just wanted to be like, well, I don't know, will it work? I want to give it a try. I'm kind of curious about it. Other people really liked the approach that it took, kind of more of a whole systems, they liked the fact that, it's been around for a long time. And other people, felt that same way about cognitive behavior therapy for insomnia, that they didn't want, that they felt that really resonated with them more.
It's fascinating, isn't it? Because it's something that we really don't understand, and yet acupuncture seems to work when you look at within those symptom clusters for select populations. I think mindfulness is also something that works for symptom clusters, as does yoga, and I'm really quite intrigued by where these fit in.
So that's, actually. So as part of my doctoral research with Dr. Linda Carlson at the University of Calgary, we did a comparative trial of cognitive behavior therapy versus the mindfulness-based stress reduction. And actually we found that was a non-inferiority trial. And what we found is when we looked immediately after treatment at 8 weeks, cognitive behavior therapy for insomnia was better than the mindfulness-based stress reduction program. But then when we followed individuals up to 3 months, the people who were practicing mindfulness caught up to the people who had initially benefited from the cognitive behavior therapy. So, it's like for the people who want to learn a skill that they're able to practice and, that they're able to do it versus other people, may prefer a different treatment style.
So this is so meaningful research, and it's helpful for clinicians, because I find that I notice that our patients are expending a tremendous amount of time, energy, resources, pursuing these types of recommendations in earnest and really being diligent about what we're recommending. And your research actually helps prioritize, what should be kind of our first line and second line, even if we're going to be using a lot of these multimodal interventions together, really to unravel this cluster of symptoms. So thank you for that.
But it's also patient centered, which is where we need to go in this, because not everybody's the same. They're culturally biased in different ways and have different preferences, and then on top of it, they have different symptom clusters. And you really want to target, when we have such complex things going on, including whether somebody's on steroids and all the different factors that go into what is causing their symptoms, to have it patient-centered and focused on what's the right thing for that specific patient. This is going to be targeted to them. I thought that was fantastic as well. I want to take a step back though, and maybe Ashwin, you can walk us through this. Just take us through kind of as a clinician, how you assess somebody with sleep disturbances in the journey of cancer. And I'm going to show this diagram as we do it. But take us through, how do we start thinking about it, and walk us through kind of to the point where we can actually start maybe thinking of an integrative approach.
Sure. Well, I always begin by asking, my two favorite screening questions, which are, on most mornings, are you waking up feeling refreshed? And secondly, do you feel like you have enough energy to get done what you need to get done during the day? You can also ask quite broad questions such as, are you overall satisfied with your sleep quality? And just from asking those preliminary questions, you can oftentimes gain an appreciation for what is the more predominant contributor to the sleep concern. Is it a quality concern, in other words, insufficient sleep quality, or is it insufficient sleep duration that is probably the bigger determinant? So asking really broad questions about sleep. I find that people have I went into sleep because I'm fascinated by all the different physiologic processes that go on. So without any active input from us, this is we're sort of on autopilot, and so many wonderful things are happening in our bodies. It's just always enthralled by that. And I find that other people. Oftentimes people are, this is a favorite subject of water cooler talk too. I mean, people like to talk about, I didn't sleep so good last night, or, so.
I have a question though. I mean, because it's so prevalent, right? It's so prevalent. And I think sleep hygiene is a major issue for many people. And I just wonder, I used to meditate outside in the morning early. And I don't know how many people do that right now, but I used to. And it was fascinating to me that every single animal has an absolute precise timing they wake up. Like the birds would start chirping at the exact same time every day. And we don't do that. I mean, if I'm in a good rhythm, yes, I will wake up at a certain time and my clock is right. How is it that people get this messed up? I mean, is it just sleep hygiene or what you said about light? I mean, it seems to be a human problem, is my point.
I would argue, I would suggest that if we stopped getting in the way of our sleep, if we stopped trying to force our rhythm to meet the demands of our employer, or what, if we followed our natural sort of rhythms, we would fall into something similar to what you described. And I guess people who go camping, might actually relate to this, right? Where you don't have an alarm waking you up, but you're in a tent and you hear the birds and you see the light, and, you get better sleep when you're camping and you kind of settle into this routine. It takes a while for your body to get out of that disruptive, maybe, fast paced routine that you were in. But I think we would actually fall into a more normal pattern, understanding that there are circadian variances, right? So there's people who are going to be more naturally more early bird, then there's going to be the night owls, and then most of us are going to fall kind of somewhere in between there.
There are also variations with regard to how much sleep we need. There are physiologically longer and shorter sleepers. So, oftentimes it's our misconceptions about sleep that fuel these anxieties themselves. So, I often find that people who are physiologically shorter sleepers, they're really striving so hard to become, what they've heard should be what is normal. I should be sleeping 7.5 to 8 hours. But actually, a lot of people, sometimes they're okay with 6.5 hours of sleep, and they're just short sleep duration sleepers physiologically, and to allow for that is really important. I think that one of the things that we habitually do is set the expectations for ourselves so high. And that is really oftentimes what can contribute to fueling these misconceptions about sleep. So that's what we oftentimes address from a sort of cognitive reframing standpoint. Is just let's befriend sleep. Let's make sure that we are. Go ahead, Sheila.
No, I wanted to double down on what you're saying, because it doesn't help that the media and a lot of medical professionals are going to elevate the patient's concerns about sleep, especially sleep quantity. And patients come to me in my practice with significant fears that if they don't get enough sleep or the proper quality sleep, that is going to contribute to their cancer coming back or their cancer getting worse. And so as soon as sleeping becomes a life or death activity, you've almost guaranteed you're not going to get it, right? So, the anxiety that the world now, I'm happy that people are paying more attention to sleep. But it has come at this cost where now it becomes a goal for people to strive to this, like, I'm going to be the best sleeper ever, or my sleep becomes what's going to keep me alive. And that kind of anxiety just certainly doesn't help.
And
Well,
our,
that's
go ahead,
yeah.
go ahead, Judith.
No, and that's really interesting because there are some papers being written and some that you've quoted, Sheila, on the impact of sleep on the immune function, on good sleep and the relationship between developing infection. So how do we know if somebody's sleep is good enough, even if it's only 5 hours?
So that is really tricky. And you're right. There is some evidence that certain types of sleep disruptions might be associated with adverse health outcomes. So like sleep apnea, for example, that one, there's some clear directional effects that, that's associated with worse sleep outcomes. Insomnia isn't always associated with short sleep duration. It's just that people are spending a lot of time in bed trying to get that sleep. So they might be spending 12 hours in bed, but they're still getting actually 7 hours of sleep. So insomnia itself, or problems falling asleep or staying asleep, may not be actually associated with worse health outcomes. So that's why I think some of the research is conflicting. But there is better research now coming out demonstrating that, the importance of sleep for immune functioning and recovery. I try and work with people to reduce their anxiety and arousal around this, specifically focusing on, all right, yes, there is a role for sleep in immunity and health. However, it is not the only thing that contributes to health. And there's things that you have more control over that you can target versus trying to get more sleep. Because again, it's almost like the more you the more you chase it, the more elusive it becomes. So let's focus on making your circadian rhythm really strong. Let's focus on making sure that your diet is good. Let's make sure that your physical activity is good. Make sure that your stress levels are good. And then, let's sleep can follow after that. And also the short term, we're going to fix your sleep in the short term for better health in the long term. So you might have to tolerate some poor sleep while you're making these other behavioral changes. But focusing on that can make sure that your sleep is better in the long term.
And then how do you know when you're getting enough sleep?
That's a tricky one. I like Ashwin's question about can you get through the day, and sometimes other factors like fatigue can get in the way of that, and cancer-related fatigue being so long lasting. I think it's a delicate balance between quantity and quality. Definitely quantity is not the goal, but it is. How much sleep do you need to be able to function effectively during the day? And I also like to take people back to, tell me when you were functioning well. How much sleep were you getting then? Right before you had these troubles? Because sleep need as an adult really doesn't change all that much. So if you were a short sleeper, back then, and it only, you only needed 6 hours, you're probably not going to need much more than that now. But some people don't realize.
How do you guys feel about naps?
They can be helpful as long as they don't impact your ability to fall asleep at night.
I agree. My grandma used to say, after lunch, rest a while, and after dinner, walk a mile. And she's in relatively good health for her age. So, I think that as long as there is not a sleep concern ongoing, naps are perfectly okay. In fact, there's more and more evidence emerging for what is known as a biphasic sort of sleep routine. That this, if you can imagine, when we were living in hunter-gatherer communities, the matriarchs and the patriarchs of the tribe would have to wake up in the middle of the night, make sure the fire was stoked, and go down to the creek and get water. These were we sort of developed an evolutionary alarm clock that wakes us up in the evening and during any sleep period. Conversely, during the daytime, it's okay to have a little bit of a pause. So, the American Academy of Sleep Medicine used to have as its emblem the Chinese yin and yang, and nobody really broke it down for me. But I always interpreted that as, during every period of daytime wakefulness, it's okay to have a little rest, a bit of a siesta. And conversely, during every period of nighttime sleep, it's okay to have a little bit of wakefulness.
I mean, I've been told that's like 30 minutes, right? That you're not supposed to nap more than that. But is that true?
There's some reasons for that. And I think Ashwin's talking about like maybe more prolonged wake periods at night and more prolonged sleep periods during the day. But, the reason for the suggestion that naps be shorter than 30 minutes, especially during the day, is that, you get into your deeper sleep when you're passing that 30-minute threshold. And when you're in that sleep, Ashwin described it as like slow wave delta sleep, right? Your brain is really not, quick functioning very well. So if you were to be woken up from that deep sleep, you would feel groggy, you would feel confused, you wouldn't actually feel very refreshed. So it's almost like you have to have a sleep of 30 minutes or less or 90 minutes or more. And if you sleep more than 90 minutes, it's more likely that you're going to have difficulty falling asleep at night. So it's like, there is a nice balance with napping and the time, because you want to have your nap earlier in the day so you have enough time to build up sleep pressure with a neuromodulator called adenosine. You need to be able to build up that sleep pressure so you're able to fall asleep at night, and the naps would, take off some of that sleep pressure.
So I've heard this is really interesting, because you started off saying, well, if we fix your sleep, maybe the other symptoms will get a bit better. If we don't focus on sleep and we focus on reducing your stress, improving your appetite, improving your exercise, improving other parts of your existence so that you are feeling better and you get enough sleep that maintains wellness and well-being, that is potentially our aim as treating people and caring for people during their cancer experience and into survivorship, into that post-cancer space. Is that the message that is generally what you feel we are giving out? Is that the approach? Have I interpreted that correctly, or not quite? Not quite, I'm hearing from Sheila.
Yeah, I don't know, because I think that was traditionally held, right? Like sleep was often seen as secondary to something else. And so what we know from like the research in depression is that even if you treated the depression, like you've got like these sleep concerns, either like insomnia or hypersomnia, if you treat the depression, it doesn't actually always resolve the sleep concerns. And, you can have people who lead a very healthy lifestyle too, and then they still have sleep concerns. So I think, there may be instances where it's an easy fix and the sleep will resolve once something else is fixed. But in a lot of cases, it's not going to. You almost need like a combined approach, like with some really sleep focused, in addition to something else, because in many cases the problems with sleep are reinforced by anxieties and concerns that people have, behaviors that they're doing that may not be targeted or may not be changed by the other interventions. So I would say that you have to do a little bit of both. I don't know, Ashwin, do you agree?
I would agree. I think that what ends up happening is that we have this tendency to strive. Anyone who's living beyond a cancer diagnosis is striving to get better. They're really putting forth their best effort to get to feel better. And unfortunately, the paradox is that if we strive to fall asleep better, then oftentimes that's one of the perpetuating factors that can kind of fuel sleeplessness, because we're striving so hard towards what we have in our mind set as a perfect night of sleep. So I think that what Sheila was saying is that, redirecting that striving, that energy towards exercise, nutrition, those things that actually respond to our willful effort, and then allowing the letting go of sleep, the surrender of sleep to really take its natural course. I think that's what what Sheila was really pointing at earlier. And I agree. That's the same exact philosophy that I use when I'm counseling patients about getting better night's rest.
You guys mentioned some low-hanging fruit there. I think most of us, we see a patient, if they're not sleeping, okay, are you exercising enough? How's your circadian rhythm? Let's set that right. What kind of medications are you on? What other symptom clusters do you have? Once we get past that stage, and that's where they really want the integrative doctor to kind of recommend, what else can I do? What are some of the things that come to mind? I think Judith, and feel free to to chime in on this in terms of what we do, because now we're getting into clinical stuff, and all of us probably do some similar things and some different things. But, you mentioned mindfulness, you mentioned meditation, yoga, all sorts of things like that. I'm curious what everybody recommends, including botanicals.
Sure. So, I oftentimes like to start with a sleep log. There are wonderful resources out there that are available. In fact, I believe the National Sleep Foundation also has a widely available sleep log. It might be even available online in PDF form. But the nice thing about that is that, oftentimes there's a sleep state misperception. People are actually sleeping better than they think, or they're just not sleeping at, to the expectations that they have set for themselves. And I think a sleep log is a really good initial step to really just take an inventory. How much caffeine are you drinking during the day? Are you exercising? What time are you sort of shutting down and getting ready for bed? What time do you sleep? How many times do you wake up at night? When do you wake up? How do you feel? So I think keeping a sleep log is a really great initial step to befriending this whole mystery of sleep. And that's what I use initially, and then it kind of evolves from there. I do try and take personal preferences and experience with a particular modality and try and keep that in mind. If somebody has been practicing yoga or has made forays into a mindfulness practice, or enjoyed acupuncture for some other concern earlier, sometimes I use just a very organic way of identifying which of those modalities would be most beneficial. And when it comes to botanicals, I always try and counsel that a lot of the botanicals that have historically been used for sleep may have some estrogenic properties, and that you do need to be careful with that. For example, lavender. We know that lavender has estrogenic properties, but also has very nice somnolent effect in people. So I do make it a point to really to make sure that any botanical that I use is not going to actually be a detriment, first and foremost. So do no harm. And then I'm an advocate for sort of judicious and short-term transient use of botanicals in order to improve sleep quality. And the list is pretty long. Everything from lemongrass, lemon balm. I mentioned lavender. Chamomile. People use valerian, although sometimes it can cause a bit of a hangover effect in the morning after. So be watchful for that. There's hops. Hops are also very, very good. So there's so many things out there that you can potentially use, and oftentimes even magnesium. A good shot of magnesium in the evening time really has wonderful effects on a lot of my patients who are living beyond cancer. Sheila, what do you think? What have you been using?
Yeah, so the sleep diary is absolutely essential. So I go through pretty comprehensive, anywhere from I usually spend 60 to 90 minutes in the first session, really kind of digging into their present sleep concern, its development, their psychological health, their physical health, family history, and trying to understand the possible contributions of other sleep disorders as well, because they may have things like restless legs or sleep apnea or even things like nightmares or something. So understanding all of that, and I also make sure to ask somebody about like what would their sleep goals be. How do you want to improve your sleep? And I do a lot of imagery, a lot of relaxation strategies. So whether they be meditation, whether they be yoga, whether they be guided imagery, I find that as you can get really powerful, especially when you're asking somebody to detail a pleasant memory, or also kind of progressive muscle relaxation. I'll often also recommend magnesium, especially for people who might have leg cramps or restless legs, things like that. And I take a more behavioral approach that way, and I think that you meet the client each week and then you refine it. I continue to use the sleep log with them to assess the effect each week of how things are going, and then we tweak and tailor it.
And I'll chime in a little bit, and I guess I'm quite obsessed with using patient-reported outcome measures, and I use the long version of the ESAS, the Edmonton Symptom Assessment Score, that includes quality of sleep, distress, sadness, memory disturbance. And then I look at going through that and treating the whole person, including their sleep. So I love the idea of the sleep log. I think that's really important. I work with a nurse that does a lot of the sleep hygiene work. I think that it's really then looking at what evidence-based practice would suit that person that you're recommending interventions to. So every person that I see gets referred for an exercise program. Some people may really benefit from an oncology massage or a reflexology treatment just because of the relationship between anxiety and sleep disturbance, or pain and sleep disturbance, and really just trying to treat the most immediate in order to meet their needs and get them to a decent place. And then it's looking at if there's a relationship with chemo-induced peripheral neuropathy, fatigue, hot flushes, and sleep disturbance, then I'm thinking acupuncture and yoga. And so it's really looking at how you tailor that program. And then the mindfulness program is a long-term, so it's all about patient empowerment. So looking at how you empower people to have skills to then move forward and take that into their daily life, and if learning a technique that works with them, whether it's a yoga technique, a yoga nidra technique, a mindfulness practice, if they feel they would benefit from speaking to a psychologist that works with behavioural therapy or a combination of those approaches. So it's really starting with the symptom as part of a symptom cluster, and of course, getting rid of all the wrong drugs, checking the bloods. I love magnesium. I think it's really helpful. Magnesium baths as well, magnesium soaks for feet. And then because I'm also working in the medicinal cannabis space, I'm getting some very interesting patients coming my way. And I talk a lot about sleep, and our study in brain cancer and cannabis showed an improvement in sleep was really, and then in quality of life was significant. And showing that the improvement in sleep with using medicinal cannabis, that then improves function and physical function as well as cognitive function. Is quite amazing. And so it's looking at where that fits in, which makes me think about the role of the endocannabinoid system in sleep disturbances. And so that's a new field, and it's very interesting. But as a result, most people I prescribe cannabis for their refractory pain will say, look, the main thing is my sleep is so much better. And so it's looking at what botanical would I choose. Magnesium and cannabis are up there, but I can't prescribe cannabis first line. but it is looking at where does this fit into our offerings in the future.
And
so I think it's fascinating.
It's really where we still have a lot of experience that comes into play as clinicians, because it's, the studies are there and they give you a menu, but you really have to apply that to that patient. And when it comes to things like botanicals, for example, I use ashwagandha sometimes. I mean, the list goes on, and you end up, more or less developing what you have seen work. You mentioned cannabis. You get a sense, okay, well, if I have this type of patient, this is my go-to, and I'm not going to do everything in every patient. And that ends up being really satisfying, because sleep is one of the best things. If as an integrative provider, we have probably more tools that we use, and it's really satisfying to fix one thing, which is such a pain for people if it's not working. I'm curious. I just want to throw this out there. Does anybody recommend benzodiazepines? I'll admit, once in a while I will use them for those people who are on steroids and their life is messed up. And more as a medical oncologist, I will throw that out there sometimes, and I wouldn't admit it to people who ask me on the street. But I know that long term it's a problem. I'm just curious, what other people think about that, or would suggest.
So, I mean, whether it's a botanical or a prescription medication like a benzodiazepine that I'm using, I think, part of the conversation has to be, look, this is a temporary measure. This is, the issue, the real concern about benzodiazepine use is its prolonged usage in order to address sleep concerns. That's what I think we can all agree should be avoided. But temporary steps, like using benzodiazepines or any other sleep aid for that matter. I mean, these are all tools within the toolkit that we should be using, albeit judiciously. So it doesn't really matter to me whether it's a botanical being used, medical cannabis, or a benzodiazepine or some other sleep medication, as long as it's conveyed to our patients that this is a temporary measure. This is a bridge towards a longer term solution, and that longer term solution is going to require some skill building on your part, whether it's developing a mindfulness practice or a yoga routine, or using yoga breathing, guided imagery, creative visualization. All of these things are kind of skill building, and there's a stepwise process towards building that skill. And these sleep aids that we're talking about now are actually going to be a bridge towards those skill building steps, which are the more long-term workable solutions.
I almost think that the sleeping medication should be used for people who don't have sleep problems yet, in anticipation, and not necessarily for those people who already have sleep problems. Because I find that they're most helpful, like say if somebody, is on dexamethasone, isn't sleeping, but it's like for a predefined period of time, saying, okay, you know what, if you're having trouble sleeping, Carrie, use this, here's 5 pills, you're done. And they're like, great, they may not use them, they may use them, but they don't have anxiety, or they're not like, it's almost preventing them from being concerned about not sleeping. In the individuals who already have trouble sleeping, then it becomes almost like a lifesaver. Where it's like, if I don't have this medication, or if I don't have this, then I'm going to drown, I'm not going to sleep. And, all of this catastrophizing starts to happen. So in those individuals, if there is going to be any prescription of medication, in my opinion, it needs to be combined again with somebody else who can help them learn other things and taper off the reliance on the sleeping medication while building their own, almost like, I call it sleep self-efficacy. So belief in your own ability to sleep again. And people with insomnia in particularly, they lose that sleep self-efficacy.
And so it is really used for different patients in different circumstances, but I think those are really good responses. I think and I use temazepam. If I've got a person who has only a few weeks to live, I'm less concerned with addiction compared to the person who is going to live a very long time, and you really don't want them dependent. So I think that was a really fantastic answer, Ashwin and Sheila, to that question of benzodiazepine use. And I prescribe it really just as a stopgap. If someone's really struggling, they'll say, look, I'll just take one every now and then, but I sometimes just need to get to sleep to function for something really important the next day. As we're sort of starting to wrap up, Sheila, do you want to tell us a little bit about your work and your sleep lab? Because I think that's quite interesting and exciting.
So, yeah, absolutely. Thank you very much. I think, my purpose, my clinical purpose, my research purpose is to really increase the evidence base of interventions to improve sleep, like across the cancer spectrum, from, preventing sleep disturbances from happening to treating them once they've been established, and also using sleep, as I mentioned, almost as that gateway symptom to try and improve other symptoms. So right now I have a number of studies on the go. One of them looking at whether or not, if by treating insomnia using a cognitive behavioral perspective, whether or not that can improve perceived cognitive impairment. Adding to the literature that improving sleep, and it wouldn't necessarily have to be improving sleep with this one particular intervention, but if by improving sleep, can we have this cascading improvement in other symptoms? And I think that this is the research that needs to be done to prioritize sleep health in the context of cancer from the very beginning, from diagnosis, allowing individuals to say, all right, like, let's preserve that as part of your health. And that can also help you stay resilient as other aspects of treatment are occurring.
Sounds very exciting and really important.
Well, and one of the things too, I guess, is that there needs to be more providers, more attention paid to addressing sleep within cancer centers. So, hopefully this will raise the evidence and people will start paying attention to the need to address it.
Hear, hear. I mean, there's a great shortage, right, of sleep trained, specialists, right?
Yeah, Ashwin can speak to that as well. Absolutely.
I think relative to the need, yes, there is a shortage.
And especially within cancer centers like Ashwin, as far as being a board certified in sleep medicine, I don't know how many other people are also board certified working in cancer centers. I would say not very many.
True. That is true. Not very many.
And it's that multidisciplinary approach that I think we have in integrative oncology, integrative medicine in cancer care, that really enables us to be a space where people can openly tease out and talk about their sleep disturbances and this multimodal approach to care. So I think it sounds like the work that you're doing will contribute significantly to the way we practice and manage sleep disturbances in the future. So thank you very much.
Thank you.
Well, we could keep talking. I mean, there's just, we could easily talk for a couple more hours. I think that it's interesting that we're on 4 different time zones and have 4 different circadian rhythms going on right now. So I really appreciate the fact that we could come together and be in the same kind of place and talk about the same thing at the same time. Really appreciate it.
Thank you very much, Santosh.
Enjoyed it, Santosh.
Thank you, Judith. Yeah.
Thank you for sharing, and it's such an interesting topic.
And thank you, Judith, as well. I appreciate the fact that you could join us today, and I look forward to sharing more podcasts with you.
It's been a lot of fun, and and it helps us learn, and it's a learning process, and it's great to be able to engage with you and with others to explore the value of various interventions and understanding what goes on for people who are living with cancer and how we can use our skills to improve their lives. So thank you for the invitation to join you as co-host.
All right, guys, take care. Thank you.
Be safe, everybody. Bye-bye.
Bye.